Good evening, doctors. Warm regards from Bayer Oncology. Thank you for joining today's discussion. Thank you for joining today's discussion on prostate cancer. Today we have Dr. G. Vamshikishan Reddy, sir. Sir is a senior consultant medical oncologist from Yashoda Hospitals, Malakpet, Hyderabad. Sir, over to you.
Yeah, good evening. Thanks to Bayer for bringing out a forum to discuss on HSPC and mainly about the role of darolutamide in HSPC. And HSPC, as we all know, has evolved a long way since the time we started treating prostate cancer. So it's almost more than 85 years since probably ADT was proven to be beneficial in those patients with prostate cancer. It did have both clinical benefit in terms of PSA reduction and also the tumor responses. But over a period of time, it was proven that the PSA decrease alone is not enough and probably ADT will not hold for a long time. So when we diagnose a patient with prostate cancer and the testosterone is more than 50 nanogram per ml, we call as MHSPC. So with this, I think we have outlay of talks for the day. So we have Dr. Lakshmi Sandhya, who will be discussing about the HSPC, the classic case presentations, how to manage in the clinic. And we have Dr. Venugopal, who will be discussing about the aeronaut evidence. And then later we'll be having a case presentation followed by Q&A and we'll be concluding. So with this, I would like to welcome Dr. Lakshmi Sandhya, who will be discussing about reaching new heights in metastatic hormone-sensitive prostate cancer, the case presentation, and also the practical considerations in the management of metastatic hormone-sensitive prostate cancer. Over to Dr. Lakshmi Sandhya.
Thank you, sir. Thank you so much. So we will start now. I'll just share my screen. So I hope everybody can see my screen.
Yes, please.
So today we are going to discuss about reaching new heights in metastatic hormone-sensitive prostate cancer. And I do not have any particular disclosures, and the presentation has been provided by Bayers. So let us start by asking a simple question. Does every patient with metastatic prostate cancer have the same disease? So prostate cancer has evolved in various stages. We know that there are localized disease, there is biochemical recurrence, newly diagnosed, metastatic resistant, hormone resistant, hormone sensitive. So not necessarily that each of these occur at any particular sequence, but ultimately every patient who dies from prostate cancer ultimately suffers with a castrate resistant disease. And historically, all the therapies in metastatic castrate resistant prostate cancer had shown a survival benefit of only 2.5 to 4.5 months. So the ultimate take home is don't wait until there is castrate resistant disease. We should act a bit early so that all our patients have a better survival. So, as we all know that the backbone of treatment in prostate cancer is androgen deprivation therapy, and ADT is the backbone in treatment of prostate cancer as ADT suppresses testosterone, in turn leading to tumor response as prostate cancer cells depend on androgen. Eventually, cancer learns to grow despite castrate testosterone, and if the last stage is difficult to treat, then where should we really intervene? So the opportunity to treat is when we are in the sensitive part of the disease. So modern therapies now focus on treating aggressively, during the hormone sensitive stage. And what is the benefit of doing so? Longer survival, delay in castrate resistant prostate cancer, better overall survival, and fewer skeletal complications. So I would say metastatic castrate hormone sensitive prostate cancer is now the therapeutic window where we can change the natural history of the disease. So, as we all know, the famous Stampede trial, which enrolled de novo metastatic disease, which high risk locally advanced diseases, which included Gleason score of more than 8 to 10, PSA of more than 40 nanogram per ml, and they included around 1,900 patients roughly. And the arm which received only ADT had shown very poor survival, and the median OS was only roughly 11 months to ranging from 3 years. So is ADT alone enough? Obviously, the answer is no. Nearly all patients progress rapidly, and the take home is ADT is an absolute treatment as of now. So so we can now do so much with the modern therapy. Coming to the arms which had received radiation in Stampede trial, those who had if the metastases are present, why should we really irradiate was a practical question. And traditionally, we say local therapy is useless once it is metastatic. But modern evidence says if it is not always so. RT had improved survival, failure-free survival, and also overall survival in low burden disease. But the same did not reflect in the high burden disease. And why is that so? And what's the rationale behind? The primary tumor in a low burden disease can seed metastasis, and once it is controlled, it can actually give a better benefit compared to a high volume disease which undergoes other kind of therapies. So coming to evolution of treatment, we all know that 2013 was the mark of GET UG trial and the CHART trial, which included docetaxel, which had shown quite a bit of benefit of adding chemotherapy in prostate cancer. Later on, Stampede had revolutionized by adding abiraterone, and then Titan and Enzamet, which included apalutamide and enzalutamide respectively. Again, in the newer era, we have the PEACE trial and Aracin, which has really shown a lot of benefit. Now we have wealth of data supporting concomitant therapies. So what do we choose now? Let's dissect the data now. So coming to Chartered trial, which was on metastatic hormone-sensitive prostate cancer, where they used docetaxel, and they included high volume and defined it as any visceral met or bone met of more than 4 bones, one beyond vertebrae, and also the Gleason score. So in the high volume, docetaxel definitely improved overall survival from almost 34 months in the ADT alone arm to 51 months in the experimental arm. So gaining almost 17 months over there. And the same did not reflect in the low volume disease. There was not much of overall survival benefit when it came to low volume disease. So though docetaxel showed good response in high volume, and why do we really have that response? Because high volume disease contains more androgen independent clones as well, and maybe chemo has shown benefit in those resistant lines. So at the same time, a low volume did not show that benefit. So coming to Latitude trial, which included again high-risk metastatic patients with Gleason score of more than 8 and more than 3 bone lesions and visceral metastasis. And the result again says addition of ADT and compared to the placebo arm had shown benefit in most of the subgroups and all the other aspects as well. And abiraterone was the first to show that hormone treatment can be effective, and this really made us understand the disease better. So No, coming to why was 5 mg of prednisolone used in abiraterone? So we all know that use of abiraterone, which is an inhibitor of CYP17, blocks the androgen synthesis from the testes, adrenal glands, and tumors. And also, this blockage leads to increase in mineralocorticoids, leading to hypertension, hyperkalemia, and edema. And definitely, prednisolone is a must. And addition of now we understand that though abiraterone has shown very good benefit, we are worried about the toxicity profile of abiraterone, and as you can see, the grade 3 toxicities compared to placebo was definitely more in the experimental arm of ADT abiraterone, where hypertension, hypokalemia had taken over. So again, a point to be of concern. Then comes Titan trial, where apalutamide, which is a second generation androgen receptor inhibitor, works in high volume and low volume disease, as the slides say. The progression-free survival, overall survival in high risk and low risk were significant. And it had shown quite a bit of benefit. And the toxicity profile also wasn't that bad compared to what abiraterone really had. So no steroids were required, and the particular toxicity that we were worried with apalutamide would be hypothyroidism and bone disease. So overall, abiraterone, irrespective of the disease, had a good tolerance level and also showed good data. Coming to enzalutamide again, unlike abiraterone, enzalutamide blocks the androgen receptor signaling and has shown good PFS benefit and OS benefit. And subgroups show that the p-value were not very significant compared to the overall population. So then comes the era of combined therapy, where we have trials like PEACE-1, which included de novo metastatic disease, and they had randomized patients into standard of care plus standard of care with radiotherapy. And during PEACE trial, actually, the data on docetaxel had come up. That is when they have a mixed arm where they have standard of care alone, and then the other arm was standard of care with abiraterone plus prednisolone. Over time, the standard of care changed, and then docetaxel had come in place. So both the groups received docetaxel and ADT, and the other group received abiraterone, prednisolone, docetaxel, and ADT. So again, their definition of high risk was as per the charter trial, and triplet regimen definitely had shown very good improvement in radiographic PFS and also overall survival. And the benefit was more in high volume disease compared to the low volume disease, as the Kaplan-Meier curves definitely show. So high volume disease, yes, clearly shows survival benefit. Low volume shows a lesser benefit, and current evidence also supports triplet regimens for high volume disease. So far, all the studies, we understood that docetaxel definitely has shown benefit. Abiraterone, yes, but we are concerned with the toxicities. When it comes to triplet, the combination of abiraterone, prednisolone, and docetaxel has shown benefit, but in high volume disease. Now comes the ARASEN study, which is a global randomized double-blind placebo-controlled trial, which is a phase 3 trial, where they had included 1,306 patients with metastatic hormone-sensitive prostate cancer with good performance status, and all the patients received ADT with docetaxel. And one of the arm received darolutamide, the other arm did not receive darolutamide. And their primary outcome measure was overall survival. And as we see, that 87% of them completed almost 6 cycles of docetaxel, and adverse effects between the arms were almost identical, mostly pertaining to the chemotherapy arm. Now, the arm which received darolutamide had shown a very good survival benefit with a hazard ratio of 0.68. That means we are preventing 32% of there is a 32% of reduction in risk of death, and the benefit is observed across all the subgroups, both high risk and low risk, which is again a good point to be noted. So coming to the secondary endpoints, which are, again very important. If you see delay in castrate-resistant prostate cancer, time to pain progression, time to subsequent agents and and skeletal events. All of these suggest that the experimental arm was doing way, way better than the control arm, and patients of all stages were doing well. So again, undetectable PSA, no less than 0.2 during the study period, had shown better prognosis and longer PFS benefit and longer OS benefit. So these subsequent slides show that early reduction in PSA had almost doubling of overall survival. So more than 2/3 of these patients reached below 0.2 in the overall study, and the depth of PSA had shown good correlation with long-term survival. So the deeper the response, the better it is, and more durable is the response, is what we can take home with this trial. So the time to progression to castrate resistance is also way reduced when in the experimental arm compared to the placebo arm. So what are the things to consider? Patient able to tolerate and accept docetaxel, and the extent of disease, whether it is high volume or low volume, and what is the risk, the likelihood of hormone insensitivity clone, age and life expectancy. So it is better to hit hard before we are too late. And obviously, patient needs to be informed of all the options. And the final take home, I would say, ADT alone is no longer the standard of care. Early treatment intensification improves survival. Docetaxel mainly benefits high volume disease. All the outcomes are definitely improved by all the agents which are available, but triplet therapy provides the greatest benefit, especially in high volume disease fit patients. Darolutamide has favorable safety profile with minimal CNS penetration, and the goal is to delay castrate-resistant prostate cancer and maximize the overall survival. With this, thank you very much for the opportunity, and I hand it over to the organizers.
Yeah, that was a lucid presentation. With this, I think we'll take the questions at the end. We will be discussing about the case scenarios. We'll be moving to the next talk. It's by Dr. Venugopal, the senior medical oncologist at Medicover Hospital. He'll be discussing about advancing MHSPC treatment horizons, darolutamide without chemotherapy, and about the ARANOTE evidence. Over to Dr. Venugopal.
Yeah. Hello, sir. Hi, everyone. Good evening. So first of all, I would like to thank Bayes for giving me this opportunity. So today I'll be talking about ARANOTE evidence, basically. So advancing metastatic hormone-sensitive prostate cancer treatment horizons, darolutamide without chemotherapy. That is the ARANOTE trial, basically. So these are my disclosures for today. Yeah. Next slide, please. Yeah, the standard of care in metastatic hormone-sensitive prostate cancer has evolved to combine ADT with androgen receptor inhibitors, abiraterone or docetaxel, as we just heard in the last talk. So yeah, so I mean we have all discussed all these options. So next slide, please. So basically, despite treatment with androgen receptor pathway inhibitors plus ADT or docetaxel plus ADT, a large proportion of patients, will progress to the metastatic CRPC within almost 3 years. So there exists an unmet therapeutic need. So basically, Arasen's, it's a phase 3 study in combination with docetaxel, already showed beneficial efficacy and safety profile in the same setting, leading to its approval in India in 2023. So what we are going to see from the ARANOTE trial is, without chemo component docetaxel. Next slide, please. We'll be discussing in detail about. So this is the background. Darolutamide plus ADT with docetaxel is a standard of care for metastatic hormone-sensitive prostate cancer. As we just heard in Arasen's, the triplet darolutamide plus docetaxel plus ADT demonstrated favorable efficacy and safety versus ADT plus docetaxel in these patients. So ARANOTE was designed to evaluate Daro plus ADT versus ADT to provide a new treatment option for these patients without the chemo component. Next slide. Next slide. Yeah. So this is the ARANOTE study design. It's basically by design, it's a randomized double-blind placebo-controlled phase 3 study where close to 665 patients metastatic hormone-sensitive prostate cancer who are histologically or cytologically confirmed for the same adenocarcinoma prostate with ECOG PS012 were randomized to receive darolutamide plus ADT versus ADT alone in 2:1 fashion. So darolutamide 600 mg BID dosing. So the primary endpoint of this trial was radiographic PFS, and we have secondary endpoints as OS, time to initiation of subsequent antineoplastic therapy, time to CRPC, time to PSA progression, and rates of undetectable PSA, that is PSA less than 0.2 nanograms per ml, and other pre-specified endpoints also we have. And so it's double-blind phase until primary analysis. Then open label darolutamide, 100% crossover to open label darolutamide. And the selected endpoints were OS and safety. Yeah. So we have the stratification factors, visceral metastasis, and prior local therapy received or not received. Next slide. So these are the patient demographic and clinical characteristics at baseline as we well matched between darolutamide plus ADT versus ADT alone, the placebo group. So where roughly the important features, if you look, Gleason score 8 or more than 8 at initial diagnosis were close to 70% in Daro plus ADT. And in terms of de novo mets at initial diagnosis, 71%, and recurrent close to 20%. Next slide. Yeah. So I mean, just can you go back one slide, please? Yeah. One slide back. Yeah. So I mean, so disease volume also, if you see here, high volume disease constitutes around 70% versus low volume disease close to 30%, and the presence of visceral mets were closely in the 12% in each group, and prior local therapy was received almost in 17-18% of the patients in each arm. Next slide, please. Yeah, so this is the country representation across breakthrough clinical trials for prostate cancer treatment. As we see here, the ARANOTE these are the regional representations from China, India, Taiwan, Australia, and New Zealand. So in that proportions, what we see here, roughly 15% and Indian 14%. Yeah, next slide. So this definitely we have good share of our representation from India. Yeah. So darolutamide plus ADT significantly reduce the risk of radiological progression or death by close to 46% versus placebo. So we can see clearly here. So the median PFS not reached in Daro arm versus 25 months in the placebo arm, where hazards is 0.54 and p-value being significant. So a risk of progression or death reduces by 46% in when you use darolutamide plus ADT versus placebo plus ADT, which is statistically significant. And if you see the 95% confidence intervals also well below 1, 0.41 to 0.71 with hazards of 0.54. So statistically significant benefit in terms of PFS, radiological PFS with darolutamide in combination with ADT over ADT alone. Next slide. So the benefit of darolutamide plus ADT on PFS was consistent across subgroups, including patients with high volume disease, high and low volume disease. As we see clearly here, the plot, all the diamonds are towards favoring the darolutamide as over the placebo arm. So as we see clearly in terms of like whether it is high volume disease or low volume disease and presence of visceral metastasis or no. So all these subgroups favored darolutamide in terms of radiological PFS, as we can see clearly from this plot. Next slide. Yeah, so high volume and low volume, see, it is not powered to demonstrate the same, but yes, definitely yes. Yeah, next slide. So darolutamide plus ADT demonstrated benefits across all secondary endpoints as well, like OS, if you see the and time to metastatic CRPC, time to PSA progression, time to initiation of subsequent systemic therapy, and time to pain progression. All these, as we can see clearly from this plot, all are favoring darolutamide over placebo. But we should see here overall survival. If you see the hazards being 0.81, yeah, and time to metastatic CRPC hazards 0.40. Time to PSA progression 0.31, time to initiation of subsequent systemic therapy 0.40, and time to pain progression 0.72. Meaning that so everything definitely favors darolutamide, but at the time of primary analysis, OS data is immature. And since OS is immature, patients are followed up for more survival. So all remaining per protocol placebo patients offered crossover to darolutamide after the primary analysis, where we saw in the study design. Next slide. So, yeah, time to CRPC here you see darolutamide plus ADT median not reached versus 13 months with ADT alone in the placebo arm. So hazards being 0.40, statistically significant benefit in terms of time to metastatic CRPC. That is, metastatic CRPC is delayed significantly in darolutamide plus ADT versus placebo. And the similar way, time to pain progression, again, which is very important if you look in terms of prostate cancer, because they all have symptomatic skeletal issues. So time to pain progression, darolutamide not reached versus 29 months with placebo, hazards being 0.72. Again, significant benefit in terms of time to pain progression also. Next slide. So, yeah. So the combo has achieved deep and durable PSA responses also. So time to if you look at PSA less than 0.2 nanograms per ml at any point of time during the treatment, so this is what we see here. 62% have achieved undetectable PSA levels in Daro arm versus close to 18% in the placebo. And time to PSA progression, darolutamide arm not reached medians versus 16 months, again statistically significance with hazards being 0.31. So meaning that 60%, close to 60% in the darolutamide doublet arm attained PSA undetectable levels. This represented or a 69% improvement in time to PSA progression in the same versus ADT alone. So definitely significant benefit in terms of achieving deep and durable PSA responses as well. Next slide. So this is what we were just discussing in terms of high volume and low volume. Also, if you see, a higher proportion of patients achieved undetectable PSA with darolutamide versus placebo in both the high volume and low volume subgroups. If you see, patients achieving PSA was less than 0.2 nanograms in high volume, close to 54% versus 15%, and in the low volume being 82% versus 25%, if you speak at any given point of time. So definitely better with darolutamide compared to placebo. Next slide. Both in high volume and low volume. So, we know that previously we had some issues about PSA depth and, but these studies with darolutamide has clearly shown the correlation between the depth of PSA responses and the clinical benefits as well. I think we have seen in the previous trial. Yeah, next slide. So subsequent life prolonging anti-cancer therapies, these are all the, no. Can you just go back one slide, please? Yeah, so these are the subsequent anti-cancer therapies we can see here in the darolutamide arm. So patients with subsequent life-prolonging systemic anti-neoplastic therapies close to 30% versus 42% in the placebo. So as we can see clearly here, they have gone ahead to receive docetaxel, abiraterone, enzalutamide, apalutamide, cabazitaxel, depending on. But overall, the percentage requiring subsequent anti-neoplastic therapies, 32% versus 42%. Next slide. So when you look in terms of incidences of treatment emergent adverse events, because we are using darolutamide versus placebo, where the incidences were similar between the treatment groups and discontinuations were lower in the darolutamide arm. So where you can see leading to the, adverse events leading to permanent discontinuation of darolutamide or placebo was less in the darolutamide arm, 6% versus 9%. And if you take in terms of any adverse events also, it's for similar. Grade 3, grade 4 were also similar, and grade 5 was also similar serious adverse events, meaning that so it's a very much pretty tolerable drug, darolutamide. So median treatment duration was 24 months in the darolutamide arm versus 17 months in the placebo. So the safety profile was independent of the PSA response and consistent with the favorable tolerability, what we know from the previous data. Next slide. So, so there is these are the most common adverse events which were almost similar if you look in terms of most common adverse events occurring in more than 5% of patients in either group, almost similar between both. So, and we heard in the previous talk also. So the fatigue is a little higher, definitely in the darolutamide plus ADT. Next slide. Yeah, so the rates of adverse events commonly associated with ARPIs were similar across the treatment arms. Next slide, please. Meaning that it's a pretty much well-tolerated drug, as we all know, and especially conferring the benefit in the elderly patients. So darolutamide confers a positive impact on quality of life as well. So it's extended median time to deterioration FACT-P total score by 5 months versus placebo. And it is the first and only androgen receptor inhibitor to demonstrate clinically meaningful delays in the pain progression and overall well-being, as we see from the curve here. So basically, time to deterioration in FACT-P total score, if you see, this is a pre-specified exploratory endpoint. So median being 16.6 months versus 11 months and statistically significant with hazards of 0.76. So this is the, this claims the first and only AR inhibitor to demonstrate this benefit in terms of the quality of life as well. Next slide. Next slide.
A few seconds, sir, because it is taking.
Yeah, fine. So I was just looking in terms of the time. So basically, meaning that darolutamide doublet therapy demonstrates clinically meaningful delays in deterioration of overall well-being, especially on social, functional, and urinary symptoms domain, as we see clearly here in terms of social or family well-being, hazards being 0.79, and functional well-being hazards being 0.78, and In the similar way, urinary symptoms also hazard being 0.78, favoring the darolutamide plus ADT over placebo plus ADT. So meaning that, so actually these are all the problems which we see commonly in all elderly patients, actually irrespective of the primary site, but more so in prostate. So these are all actually in these domains, darolutamide really did better and fared better over the placebo. So worth noting, definitely. Next slide. So this is the conclusion of these are the conclusions of my talk for today. So darolutamide plus ADT significantly improved radiological PFS in patients with metastatic hormone-sensitive prostate cancer. It showed a benefit across all secondary endpoints, as we saw, and associated with the deep PSA response regardless of baseline PSA. It is the first and only androgen receptor inhibitor to demonstrate clinically meaningful delays in terms of pain progression, overall well-being, including all these domains: social, family well-being, functional well-being, and in terms of the urinary symptoms. So it definitely had a favorable safety profile. So concluding that Daro plus ADT without docetaxel chemo component should become an additional standard of care in this setting. Thank you. So with that, I would like to end my talk here.
Yeah, thanks, Venu, for the lucid presentation. And I think probably we'll be going with the panel, and I think we'll be trying to answer a few of the questions which you have presented. So with this, we move on to the next part of how to deal it in the clinic. So I'll be sharing about one of my patients who was started very early when Dara was launched, and is still continuing on this drug. So I'll be just going through the practical considerations in the management with the case presentation, and from there we'll be having the Q&A. And yeah, let me share my presentation. Yeah. So we do have data the either ways, but when to use which therapies again question, and probably this is where we'll be discussing about the options. This patient actually presented in 23 March with low backache, and he went to a physician who found that there was retroperitoneal lymphadenopathy. There was a PSMA PET CT done because the prostate was also increased in size, and his PSA was very high, which showed the involvement of mediastinal cervical lymph nodes, and also there was abdominal lymphadenopathy and uptake in the prostate gland. Biopsy showed adenocarcinoma. Gleason's was high, it was 9, Gleason's 5+4. And to confirm that it was a metastatic disease, we also did biopsy from the left cervical node, which showed us metastatic adenocarcinoma. Family history was quite significant for this patient, with 2 siblings who had cancer. So the other sibling which had multiple metachronous primaries, CA breast, followed by lung, and then endometrium. All 3 I was treating this patient, and we have done the genetic testing which confirmed Lee-Fraumeni syndrome. The final diagnosis of this patient was stage 4 prostate cancer, de novo metastatic. It was hormone-sensitive prostate cancer. Gleason's was 5+4. A PSA was quite high. It was 290 at baseline. Type 2 diabetes well controlled. The number of nodes only, it was abdominal nodes, and the volume was low. In view of the significant clinical history, we also suggested P53 testing for him, and we have done both the CGP and also the MMR testing. We can see that the CGP did not show much information. The PDL1 score was 0, but what was more important was the HRR testing which we had done, which was showing a TP53 mutation. So you can see the TP53 was pathogenic, and the same mutation was detected in the sibling also. And MSI was stable for this patient. So this was the genetic information, and HRR germline showed a confirmatory Lee-Fraumeni syndrome for this patient. We have discussed the treatment options, and he was having significant backache because of the retroperitoneal nodes. And at the time, Arasens was just released, and we told him about this, and we planned for triplet therapy. So we started him on EDT every 3 monthly with docetaxel 75 mg per meter square, and darolutamide was started at 600 mg BD. By the time we completed the 6 cycles of chemotherapy, his PSA came down, and post that we continued as a maintenance of both ADT and darolutamide. We can see that the PSA has gone further low in May 24, and the patient again was in a dilemma because there was only two nodal areas which were still lighting up, and the disease burden was very low, and patient was taking opinions elsewhere also. And after discussing in MDT, we radiated the prostate in the two nodal areas, and then we are continuing on leuprolide and darolutamide. So it's almost 3.5 years plus this patient is on darolutamide. The PSA as of now is very less, and we are in a situation now we are thinking probably to go with intermittent ADT versus continuing the same drug. We can see the PSA graph from 290. We have reached probably undetectable zone now, and this was the initial nodal burden. You can see the cervical nodes, only these two nodal areas were there, and the main bulk was this retropetal nodes, which was the cause of his symptomatic backache. And the patient responded very well to the chemotherapy, and the side effects when both of them given together, as we have seen from the Arasens data, it's tolerable. And other than the routine side effects of docetaxel, he was asymptomatic, and he's continuing on darolutamide at full dose till now. And the current follow-up protocol, we are doing it every 3 monthly, the leuprolide with darolutamide. So Arasens has an effective and well-tolerated triplet regimen in HSPC patients, and apart from its efficacy, the safety data and tolerability is very well tolerated in our Indian patients. And post-chemotherapy, this maintenance therapy can be continued, and the quality of life, as was shown, is very well maintained with darolutamide. So with this, I think we'll move to the panel questions, which probably will be the discussion thing. Yeah. So we have seen the data. I think in 26, where are we with the HSPC treatment? So we have come a long way from ADT alone. From there, we had data from Chartered and Latitude, where again, low volume, high volume, see the dose, and probably you will see whether we'll go with docetaxel or abiraterone, which showed the OS benefit. And then we had Enzamet, ARCH, and Titan data. And from there, we will be discussing in 2026. What's more important is doublet ARPI for most. Triplet therapy, I think probably will be going for fit high volume disease and aggressive MHSPC or the high risk. Probably in the future, we'll be going for more biomarker directed therapy. So high volume patients with high risk disease and fit triplet is preferred. And the high risk is again a debatable thing, because that's where probably the patient whom we have treated fits in, because de novo metastatic and with the leave from any this always the high risk thing. And the low volume, I think probably we can go with the doublet, which again Dr. Venu has presented, and probably for the biomarker guided therapy, probably it's most of the times in the trial setting. So Dr. Venu, so which patient subtypes will tip you towards doublet or triplet intensification? So how is it in a clinic you choose your patient?
Yeah, sir. So basically, when we are, discussion is between the triplet and doublet, definitely those patients who have got high volume, ECOG PS01, young, I mean, considerably young. So prostate being the cancer malignancy of elderly, but whatever, young age group relatively. So these are the areas. So high risk, as we were just discussing, but high volume, high burden of the tumor, where you want rapid responses with fit patients, good ECOG PS. And of course, when we are going to add chemo component, we would look in terms of adequate reserves, in terms of organ reserves, adequate organ reserves. So these are the patients I would like to intensify with triplet.
Dr. Lakshmi Sandhya?
So almost similar. So those who fit into the high risk group, which is de novo metastasis, who are fit and can tolerate chemo very well, and those with no huge disease burden, visceral metastasis, high Gleason score. So these are the patients. Particularly, I would basically look for how frail they are or how fit they are. If they are very fit, can tolerate the toxicity of chemotherapy, then definitely a triplet regimen to intensify the therapy at the earliest. Those who are frail, elderly, or low burden disease who really may not require so much of therapy, I would barge on to give a doublet therapy.
Okay, I think that's a point taken. So most of the times we go for the triplet based on the volume of the disease, the high visceral burden, when we have significant symptoms and probably fit patient. A frail patient, I think, probably fits into the doublet regimen. So when abiraterone enzalutamide combinations feel suboptimal, what are the common clinical or practical triggers which help in choosing the drug you are going with? Dr. Lakshmi.
So when it is comparison between abiraterone and enzalutamide, again, abiraterone, we are concerned about so many toxicities related to mineralocorticoid excess, and again, when we give steroid for long term, and especially I have seen patients who are on steroid for past 2 to 3 years, they tend to have all Cushingoid features, and then the steroid related toxicity also sets in. Those steroid use is here because we don't want to have toxicity of abiraterone. So when it comes to doublet, I will choose my patients again based on how tolerant they would be, what is their average life expectancy, how elderly they are, and again, enzalutamide is also not a very easy drug to deal with because it has its own side effects, and also it can penetrate blood-brain barrier. So I would still choose abiraterone prednisolone when it comes to little middle-aged 60s around who can tolerate some amount of steroid toxicity, and because they would do better on that combination.
Yeah, Dr. Venu.
Yes, sir,
So,
almost the same points. So when we are considering, abiraterone, we should look and carefully keep in mind about the metabolic impacts of the molecule abiraterone. So, and even with 5 mg of prednisolone, also we have seen the data. I mean, almost all the toxicities, again, even with the 5 mg per day also. So the metabolic impacts we have to keep in mind with abiraterone. And enzalutamide, as we know, it crosses the blood-brain barrier and known to have seizures and cognitive impairment as well. And especially when we are talking about elderly people, we know that they have less reserves, and cognitive impairment is a major challenge. And seizures, of course. So these are the points when we are actually picking up enzalutamide, we need to keep in mind. And especially elderly people, they are they have polypharmacy interactions. The drug what we choose, interactions also need to be less, drug to drug interactions. So when we look in all these issues, daro really is a good option in terms of minimal CNS penetration, minimal drug interactions, as well as less metabolic impacts, as we see with all these.
yeah, I think both the drugs, most of the times, as we are seeing, keeping the cost and finances aside, abiraterone, I think the hepatotoxicity and the need for steroid and enzalutamide because of the neurological side effects, I think something which we are not comfortable with when we are using on a day-to-day practice. Uh, Going to the next thing, so I think Aranode strengths and the other arches and titan. So how does that affect the first line confidence, Dr. Lakshmi?
So, do you consider? So
Do
I
you
think
consider
yes, sir.
Aranodes
So
as are effects
Aranode,
comparable?
yeah, when compared to the other first line therapies, definitely it has performed quite well. I have not gone through too much of details of Aranode per se, but overall, compared to other combinations in the first line? Yes, because of the toxicity profile that Daro has, I would suggest that, yeah, it is better.
So Aranet is mainly about the doublet where ADT with Daro is compared with ADT alone, and I think the efficacy thing it has great hazards. I think 0.54. Dr. Venu.
Yes, sir. So definitely, when you look in terms of the radiological PFS, so definitely as we just saw, so hazards being 0.54, so significant benefit in terms of PFS, radiological PFS compared to the placebo, almost reduced risk of death or progression by 46%. P-value being significant, definitely yes, data really is promising. And I mean, see, what comes to our mind is tolerability of the drug and good safety profile of the drug when you are considering for doublet.
Yeah, I think similar PFS, but the hazard ratios and safety and quality of life is something which puts this
Quality of life.
on. Yeah. How do you see that the volume data? Because I think we have seen a lot of change in how the high volume, high risk, low volume, low risk. So DARA with ADT with docetaxel, and how does this Arasense data support in low volume disease as I have done? Dr. Venu.
Yeah, sir. So on a practical note, what we would see and pick is the triplet versus doublet. So if a patient is really fit enough to go ahead with chemo, docetaxel, then we would like to push them for triplet.
Yeah.
So yeah, so in those patients who will struggle, definitely we go for doublet. But keeping in mind that those patients who are really fit and high burden, what we just spoke, symptomatic, where we require really good rapid responses and fit enough, definitely we would push for triplet. Because I'm telling this because when we look in terms of the study, what we saw, 87% of the patients really completed all 6 cycles. So that was really promising. So those who are able to tolerate docetaxel will be pushed for triplet. That's what I feel.
Yeah. Dr. Lakshmi?
Yeah. So, sir, I think coming to the triplet regimen, when we compare the data of abiraterone, prednisolone, and docetaxel, definitely high volume had shown benefit, low volume did not show much benefit, and the hazard ratio was not reaching significance. But when we compare the data of Eracin, it has shown benefit of in both high volume and low volume. Now, here I would want to highlight when we say low volume, it also would be including afferent metastatic disease with lesser bone involvement or some non-regional lymph nodes. Those, though come into high risk, are low volume. And probably these are the groups who are actually benefiting with triplet regimen at efferent, because that again has shown a very good dip in PSA and other aspects. So I would say in Eracin, both low volume, high volume, both have shown benefit. And triplet should be considered in those who are very fit and not frail and no other toxicities, no other side effects. I think we should consider. So, as for data, both the groups have shown benefit.
Yes, I think there is no doubt in that Arasense does support triplet therapy because it has shown the OS benefit without an increase in toxicity. That's where we are. So, but definitely we do have patients because prostate cancer most of the times is a disease of elderly where the frailty might be a thing where probably even the doublet will be an approach. So, in a practice, which characteristics define patient ideal for the doublet with darolutamide versus the alternate regimens? So, who is the patient who will be going for darolutamide? Definitely the one with deep pockets. Second, Dr. Venu, anything else?
Again, the same points, sir. When you are looking in terms of quality of life, that extra edge over the other conventional agents, definitely yes. In the absence of the financial constraints, I would push this for Daron.
Yeah. how do potential drug interactions, because we see that most of the patients in the elderly group, we see that the comorbs in Indian patients, diabetes, hypertension are usually there. And how does this help you to decide which drug you are going for, Dr. Lakshmi? Mainly
Yes,
the
sir. This is
multiple drugs in the elderly. Yeah.
yes, exactly. So this is where Darrow has better, option, or our choice would be more inclined towards Darrow in case of patients with polypharma and drug-drug interaction, something where they have to use a few drugs which cannot be let go. So apart from the financial part, I would be really inclined to use Darrow for patients who have various other comorbidities where I would be really concerned about steroids and other things. So, yeah.
Yeah, I think that's where I think Darolutamide scores over the other drugs, because drug interactions are less, and probably patients, most of them with those comorbidities, because minimal drug interactions, this is the preferred. So again, in the era of all this, how should we treat and sequence the options in the HSPC so that we do have options left at CRPC, Dr. Venu?
Yeah. So there are Ferrano-Torresian syndrome at decent should Indian. Yes, sir. So basically, all these patients, wherever you have already illustrated, so we should look at the other viable options later in the downline course also. So we would definitely do the HRR testing upfront. That's one thing we should keep in mind to use the PARP inhibitors later down the timeline after doublet or triplet. Yeah. Although we know that a very less percentage of patients have MSI high or for the usage of IO molecules later. But yes, definitely should be considered.
And Dr. Lakshmi?
Yes, sir. So, for this questions, always we have two school of thoughts. One, people would want to hit hard in the beginning and try to give as much benefit as possible in the beginning itself. There are few who would go slow and then keep the other drugs at second line, third line. But the beauty in prostate is Darrow has approval in metastatic prostate, sensitive prostate cancer. And later on, when it becomes resistant, it has to be non-metastatic. So we cannot reserve that option for later use, definitely. So only one school of thought really, wins here. We have to hit hard the moment we see. Apart from the financial part, I think any of my patients who fit into the Arasen inclusion criteria should get, because the data is very encouraging to use, and definitely the survival benefit is showing great results.
Yeah, I think with the available data, so sequencing is a thing, because we are in an era now, probably most of our patients are going for the triplets and doublets, and probably what to do at the CRPC stage is a question. So the approach, I think probably as because we have abundant data, and I think with the OS benefit we are seeing for those with high risk, high volume disease, I think we are going with the triplet regimens. And post that, once they progress and reach the CRPC stage, probably will be continuing the ADT, and probably which drug to add at this phase. I think that's where probably the HR is helping up with the PARP inhibitors and again the PRRT. So that's something which we are using more often in the CRPC setting. And again, we have cabazitaxel also. And again, for the rare patient with unstable MSI, probably the IO also does help. So to conclude, the treatment options for prostate cancer are evolving, and ADT is the backbone. So there is nothing which has changed in the last 80 years. Beyond ADT, we do have options, but this is the fundamental backbone beyond which everything adds onto this. ADT alone is obsolete, and doublets and triplets are the treatment options to go for. When to use the doublet and triplet? Again, I think for HSPC, we do have darolutamide with ADT, which has been approved, and These are for majority of the patients, and the triplet combination offers the greatest survival benefit for those with de novo high volume disease. And we should assess the patient's performance status and also the appropriate evaluations to see whether he fits into the triplet regimen. So the triplet for those with high volume disease, those who are not fit, the rest all will go for the doublet. So this is based on the backbone of ADT. So that's where we are, and I'd like to conclude my talk. And thanks to Bayer and team for bringing about platform to discuss the HSPC. And I think personal note, daratumide, I think very well tolerated drug. I had patients probably who were having the side effects with probably the other regimens, did really well on this, and probably now we are in a situation where when to stop if the disease is not progressing. So that's where we are, probably the intermittent ADT with giving a break and starting. And again, the other future questions will be on progression. We need to have evolving data, which probably will help us in choosing a regimen later. Thanks to Bayer.
Thank you, sir. Before closing, let me check the chat box, sir, if any questions are there. So, yeah. Yes, sir. I don't see any questions in the chat box. So we can conclude the session, sir. My sincere thanks to Dr. Vamshikrishna Reddy, sir, and Dr. Venugopal Aruju, sir, and Lakshmi Sandhya, ma'am, for your taking your time for the discussion. With this, we can conclude the session. Good night, sir. Thank you.
Thank you.
Good night.
Good night.
Thanks,
you.
Thanks to Lakshmi
Thanks.
Sandhya.
Thank you,
Yeah,
sir.
thank you, sir.
Thank you.
Technical team, please end up the session. Thank you, sir.
Yeah, thank you.
Technical team?
Yes, sir. Can we close the session?
Yes, yes. Please close.
Okay. Thank you, sir.